Let us begin the session with a prayer song by Sanjana and team, students of BSc Nursing third year from Care College of Nursing.
Bless the Lord, oh my soul, and worship His holy name. Sing like never before, oh my soul, and worship Your holy name. The sun comes up, it's a new day dawning. It's time to sing your song again. Whatever may pass and whatever lies before me, let me be singing till the evening comes. Bless the Lord, oh my soul, and worship His holy name. Sing like never before, oh my soul, and worship Your holy name. You're rich in love and you're slow to anger. Your name is great and Your heart is kind. For all Your goodness I will keep on singing. 10,000 reasons for my heart to find. Bless the Lord, oh my soul, I'll worship His holy name. Sing like never before, oh my soul, I'll worship Your holy name. Lord, I worship Your holy name.
Thank you for the wonderful song. May God bless you and everyone with knowledge, because knowledge is power. And now it's time for a welcome dance by Marina and team, students of third year BSc Nursing from Care College of Nursing.
ಚಂದ್ರಚೂಡ ಶಿವಶಂಕರ ಪಾರ್ವತಿ ರಮಣಯ ನಿನಗೆ ನಮೋ ನಮೋ. ಚಂದ್ರಚೂಡ ಶಿವಶಂಕರ ಪಾರ್ವತಿ ರಮಣ ನಿನಗೆ ನಮೋ ನಮೋ. ಸುಂದರತರ ಪಿರಾಗಧರ ಸುಂದರತರ ಪಿರಾಗ ಧರ ಗಂಗಾಧರ ಗಜ ಚರ್ಮಾಂಬರಧರ ಗಂಗಾಧರ ಗಜ ಚರ್ಮಾಂಬರಧರ. ಚಂದ್ರಚೂಡ ಶಿವಶಂಕರ ಪಾರ್ವತಿ ರಮಣ ನಿನಗೆ ನಮೋ ನಮೋ.
ಜನನ ಜನನ ತನನ ತನನ ತೋಂ ಜನನ ಜನನ ತನನ ತನನ ತೋಂ ಜನನ ಜನನ ತನನ ತನನ ಜನನ ಜನನ ತನನ ತನನ ತೋಂ ತೋಂ ಜನನ ಜನನ ತನನ ತನನ ತೋಂ ತೋಂ ಜನನ ಜನನ ತನನ ತನನ ಗೀತ धुनी को तक धीम नात्र कीट तो नाच रहे गोरी. के साथ तुम नाच रही गोरी ताई 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 तुम तेरे को गीत धुनी को तका धी
Yes, it's a wonderful, beautiful performance, nothing less than a professional. Thank you. So, I am so pleased to invite Mrs. Bhagyalakshmi ma'am, Principal, Shadan College of Nursing, Chairperson, Nursing Education Committee, TNAI Telangana, to introduce the chief guest, moderator, and resource person. Ma'am, you are requested to take over for further proceedings.
Thank you, Lavanya. Coming together is beginning. Keeping together is progress. Working together is success. A very good afternoon to all the dignitaries, members of TNAI, faculty, and students. I, Professor T. Bhagyalakshmi, Principal, Shadan College of Nursing, and Chairperson for Nursing Education Committee, TNAI Telangana. On behalf of TNAI President, Secretary, and all executives of TNAI Telangana branch, I extend a hearty welcome to you all for this virtual national campaign on palliative care and update. Next slide, please. Always humble and polite, known for his dignity and kindness in the society. I feel proud to take this wonderful opportunity to welcome Professor Dr. Roy K. George, National President, TNAA, to inaugurate today's event. Thank you, sir. Next slide, please. Let us now welcome the person who doesn't need any introduction and known among all of us. Her wisdom, knowledge, and her pleasant appearance motivates all of us. It's my immense pleasure to welcome Dr. Rajeshwari Muppudi, Dean from CARE Group of Institutions, Telangana, and President, TNA Telangana State Branch. Thank you, ma'am. Let me say from the bottom of my heart, success is not accident. Success is the result of perfection. And now it's my honor to welcome Mr. K.V. Hamza, General Secretary from TNIP Care, and Mr. Suresh TP, Secretary from TNIP Care. Thank you, sir. The greatest leader is not necessarily the one who does the greatest thing. He is the one who gets the people to do the greatest things. It's my great privilege to welcome Dr. Bablish Mahaver, interventional pain and palliative care physician and senior consultant, Ramakrishna Care Hospital, Raipur. Thank you, ma'am. Next slide. I'm extremely overwhelmed to get this opportunity to welcome Professor Dr. A.T. Kora, Principal, NIMS, Purnia, Bihar. Thank you, ma'am. And I'm extremely delighted to welcome Mrs. Shakila Murali, Palliative Care Nurse in charge, CMC Vellore, Tamil Nadu. Thank you, ma'am. I once again delighted to welcome and thank all our delegates, faculty, and students for joining virtual national conference program on palliative care and update. Thank you all.
Yes, ma'am. So, I request Dr. Rajeshwari ma'am to give the keynote address of the gathering. Ma'am, you are on mute, ma'am.
Okay, na?
Yes, ma'am.
Can you
it's
hear
on.
me?
Yes, ma'am.
Yeah. Good afternoon, all. I once again welcome you all for this webinar on palliative care and update. I am very glad that you all, our Telangana nursing students, are very lucky to be part of this webinar where all are meeting our eminent national leaders, Dr. Roy K. George, National TNA President. Palliative care is treatment of serious health related sufferings. It includes management of pain and other symptoms and address psychological, social, spiritual suffering of patients and their families. Like in most low or middle income countries, the need for palliative care is greater in India than in the West simply because disease specific treatment does not reach patients adequately or early enough. Palliative care also aims to reduce overall health related sufferings for patients and families living with life limiting or life threatening conditions. Palliative care is not restricted to those at the end of life. However, palliative care encourages conversations about the end of life. Palliative care advocates for a good health, which is pain free and hopefully surrounded by loved friends. In the West, there is parallel care system that takes care of people with such conditions and provides physical, social, mental, and spiritual support in home setting. We don't have such a system. We bring them into the fold of palliative care. 1 in 5 suicides in India are committed by a person living with an advanced chronic or life-limiting condition. In 2017, a Lancet Commission report recommended that palliative care should focus on all aspects of serious health-related sufferings. Unit care aims at development of sustainable, cost-effective system of palliative care with active community participation for patients suffering from long-term, bedridden, incurable, life-limiting disease, including cancer, by encouraging local people to address the social needs of patients and their families in their own areas, training the community volunteers to offer emotional support, facilitating the development of locally sustainable home care programs, and by establishing a network of committed volunteers, nurses, and doctors with expertise in palliative care to support such initiatives. Both palliative and nursing care emphasize comprehensive care, supporting the holistic needs of patients and their caregivers, including the assessment and treatment of physical, emotional, and spiritual health. The nursing workforce must be trained in palliative care skills, especially nurses who work with patients with serious illness. Nurses in all settings and at all levels of practice are well positioned to use their skills and position to collaborate interprofessionally to provide palliative care. Nurses often recognize changes in patients' health status, and these are the junctures during which palliative care may be introduced. While providing palliative care encompasses several nursing care competencies, all nurses are particularly in primary aspect of palliative care, which includes symptom management, communication, and advocacy. In addition to lack of education in palliative care, part of nurses' hesitancy to engage in palliative care may relate to the relationships they should build with their patients. Nurses may not recognize when patients are approaching the end of life. Nurses may desire to maintain hope for a cure from the disease rather than assisting patients and caregivers in redefining hope within the context of life limiting illness. Avoiding emotionally intense conversations may superficially appear to help patients and caregivers cope in the present, but may lead to ethical and moral dilemmas if palliation and end of life topics have not yet been previously discussed when urgent decisions are necessary. As it is the need of the hour that all nursing students ought to be sensitized about palliative care and its importance. With this reason, we TNA Telangana and the support of TNA headquarters, along with the DNIT Care, organized this virtual national campaign on palliative care. Now I take this privilege to welcome Dr. Roy, National TNA President, to launch the theme and address the gathering. Over to you, sir.
Good afternoon, everybody. The office bearers of DNA Telangana State Branch, led by Dr. Ajay Mukudi. Office bearers of Delhi Initiative in Palliative Care, Mr. Hamza and Mr. Suresh, Madam A.T. Kora, other respected dignitaries participating in this meeting, dear faculty members and students. First of all, let me congratulate and appreciate the effort of DNA Telangana branch in organizing this very relevant webinar on palliative care. I must thank the Delhi Initiative in Palliative Care office bearers for willing to be collaborated with the DNA Telangana branch for organizing this informative session. Palliative care is of utmost importance in today's healthcare, especially in a developing country like India, where the high number of population leads to many people, large number of people affected with terminal illness who need comfortable living and a peaceful departure from this field, which can be made possible through effective palliative care. Nursing students, when they are being trained to become professional nurses, shall have good understanding of palliative care, what it is and how it is done, and what is the importance of that in the healthcare of people. So I'm sure that this webinar will be highly useful for them, and it will give the initial exposure to palliative care, which may motivate many of them to learn more about palliative care and use principles of palliative care in their care whenever necessary. It is not only palliative nurses or palliative healthcare workers who need to have the palliative skills, knowledge about how to deliver palliative care, some of the aspects which we may need in a daily care setting as we meet people who needs such comfort measures and palliative care strategies to make them more comfortable. So with immense pleasure, I am happy to announce that this webinar is open, and once again, congratulations to each one of you for participating in this session, and I declare the program open. So the host may just enable my screen sharing. Dr. Rajesh Mukudi want to click on the curtain raiser. So just enable my screen sharing. I'm not able to share my screen.
Lavanya, you can share the screen.
Yes, ma'am.
Remember, Lavanya.
Ma'am, I'm making a co-host, ma'am.
నువ్వే చేసుకోలేకపోతే
షేర్ చేయను మ్యామ్, స్క్రీన్ షేర్ చేయను మ్యామ్.
చేసి సార్ నీకు హోస్ట్ అంటే వెయిట్ సార్ చేద్దాం.
Yes, ma'am.
చేయడానికి లేదు కదా ఇక్కడ.
Yes, ma'am. For that only I'm searching, ma'am. Is there?
నువ్వు చేసే సార్ we cannot make you co-host, so I'll ask MC only to raise the button.
Yeah. Okay. Thank you very much. And
Okay, sir. Thank
all
you,
the
sir.
best for the program. Thank you.
Yeah, thank you, sir. Lavanya, you can do it.
Yes, ma'am. Thank you very much, sir.
Thank you. Thank you.
Thank you. Yes. Our theme is on palliative care and update. Yes. Thank you very much, Dr. Raikeja, sir, for the wonderful address to the August gathering. And special thanks to Rajeshwari ma'am for the keynote. Bhagyalakshmi ma'am, it was a super lead from the front. Thank you very much, ma'am. May I now invite Dr. Hamza sir to carry forward the program with esteemed panel members. So students feel free to drop the questions through chat box. Ma'am. So sir will transfer knowledge to you. We are so lucky to have you, sir. So over to you, sir.
Thank you very much, Lavanyamma. Good afternoon to everybody. And the caveat first, I'm not doctor nor connected with the medical field. So I'm a palliative care volunteer, set up the Delights National Initiative in Palliative Care, and that's why I'm here among all of you, the real health experts. So it is again this palliative care and update. That is the subject, and there are so many participants. Over 300 are already I'm seeing, and it was a real good beginning as well, with the prayer and the dance and all. It's really gives a tremendous measure of happiness and enthusiasm for this program. So really, we are grateful to the Telangana state branch of TNI, and Sir Roy Joe sir and Rajesh Murthy ma'am and everybody all are here. And in addition, our palliative care experts, of course, Professor Dr. A.T. Kora ma'am, the principal NINS, Purnia Bihar ma'am is already one among us. I mean, the Dinipkarians, I'll say, the Dinipkar, no, the Delights National Initiative in Palliative Care. She is, from the very beginning, she is one among us, and always at our reach. And even whether she is in Bihar or she is in Kerala, wherever she is available with us for doing the programs like this online as well. So, which is a way we have been taught, maybe due to the COVID period. So now coming to the participants, all the participants are there, and all the nursing students. And as always, I will just say that whenever the first breath is taken, you are there, the nurses are there. When the last breath is taken, there also the presence of nurses are there. So that is the most important thing of the nurses in the human life. And my role is to moderate. I'm not to speak much. And I have already told that I'm not a medical professional as well. So at the same time, while going to the palliative care volunteering, what are all I'm seeing, that things, no. See, there are so many superstitious beliefs in India, whether it is in Delhi or whether it is in maybe a far away village in the corner of India. It is always there. And end of life care, and ma'am Rajeshwari Mupri ma'am in her speech, she was telling about decision of palliative care and end of life care. Discussion and decision needs to be taken well in advance. That definitely, ma'am, it is. I've seen that people with the who requires the end of life care but not getting the care, nor ready to go to any hospice center. though hospice centers are very few, even though the beds are vacant in hospice centers. So it is the requirement of the time that we have to inform everybody that what is palliative care, how to sensitize about it, and all. And to the nursing students and the other participants, I would like to tell that the this is palliative care is not a rocket science, and as a common person, what I speak about palliative care is, to begin with, when you are the in a metro train or in a bus or in any other transport mode of transport, and you are seeing a lady or a gents, somebody is standing in a corner with a big packet of MRI or CT and all, and maybe having a bald head due to the chemotherapy and effects of the radiotherapy and all, just to raise your bum and offer that seat for that patient who we may be coming after the radiotherapy session or the chemotherapy session, or going for that and having all the issues and the problems. So there, the sensitization for offering your seat or offering the comfort of the next 15 minutes or 20 minutes, that itself, from there itself, the sensitization begins. If you can convince others also this way, definitely the palliative care will go a long way in improving the quality of life of every suffering chronic patient. So let me request our dear Professor Dr. A.T. Kora ma'am, our esteemed disciplinarian, to speak about the palliative care with her perspective. Kora ma'am, the floor is yours.
Yes, thank you, Mr. Hamza.
Yes.
Can you all hear me?
Yes, ma'am.
Yes, ma'am.
Respected Dr. Roy, Dr. Rajeshwari, Mr. Hamza, Mr. Sudesh, and all others who are here, a very good afternoon to all of you. I especially thank Mr. Hamza and Mr. Sudesh for involving me with the teaching program. Though I left Delhi 2 years back, I'm still involved with the teaching program of palliative care. And it gives me a lot of happiness to be a member of this team. So thank you, Mr. Hamza, especially for involving me with the teaching. Can I have the slides, please?
Yes, ma'am. 1 minute. I'm going to share the screen.
The topic given to me is nurses' role in palliative care. When we say nurses' role in palliative care, the next slide, please. Palliative care, when we say, that is the active total care of patients whose disease is not responsive to curative treatment. Can I have the next slide, please?
Yes, ma'am.
Lavanya, presentation mode lo pettu avi.
When we say active total care of patients, as Madam Rajeshwari already said, the slide before this, the care of a patient not limited to physical care only. It involves psychological, social, and spiritual care. So, when we are not knowing
Ma'am,
that,
Kora ma'am, sorry
Yes.
for the disturbance. 1 minute, ma'am. I'm going to share it in your presentation.
Yes, you can put the slide, no problem. So what happens is, when you are taking care of a patient, you need to remember you are having a role to see to all these needs of the patients. That means you are there to take care of the patient's physical needs, psychological needs, spiritual needs, and the social needs. The present slide which is put shows the unique opportunity to maintain patients and families' hope by providing excellent physical, psychological, social, and spiritual care. This is exactly what a palliative care nurse is expected to do. Now, what do we mean by the term providing excellent physical care? A person who is in pain, you are giving care to the person for relieving the physical pain. I can give you one example. When I was in Bihar, one day, I was taking care of a patient who was screaming out of pain. He had osteosarcoma. So as I was trying to position him, he had a big swelling on his right knee, and I was trying to make him comfortable. So the physician who came there told me, "Madam, whatever you do, it's not going to make any difference for this patient because he is having osteosarcoma." I thought, oh my, I'm a palliative care nurse standing with a patient who needs my attention, and this is what the physician is telling. I didn't respond for what the doctor said, but I continued to provide the comfort measures for the patient. So there are times when you have to make sure what you have to do, irrespective of what comments you get from people around you, what other people are wanting you to say. Similarly, psychological care. A person may be wanting to express so many things, and when he or she is wanting to say so many things, if you are ready to listen, then more than half of the pain will be taken off. Social care. When a person is admitted, that person is taken away from the society in which he or she is a part of. And what happens is, he may have to leave his social circle, including his family, and then come to the hospital setup. And that itself can increase the anxiety of the patient. So we nurses have more to concentrate on psychological care. Spiritual care, when we say, it means when a person is in pain, when a person is in agony, that person won't feel like praying. That person won't feel like listening to somebody, or even that person feels like running away from that situation. Next slide, please. Here it is shown that, next slide, please. Yes. Here it is written, total care includes physical, psychological, social, and spiritual. As I have explained to you, a person who is sick is wanting to have physical care for relieving pain, social care because he is driven away, taken out of his society, psychological care because he may not be seeing anybody with whom he is having connection within the hospital, or when the person is having some sickness, he may be worried. What my diagnosis will be? When a person is entering into the OPD, that person comes with this particular question in his mind. What the doctor will say. If the doctor is telling I'm having cancer, what will I do? If the doctor is going to say I'm having tuberculosis, what I'm going to do? Those kind of questions come to the patient's mind, and then you are there to care for the patient. You are there to address to all these questions what the person is giving up, raising up, and you may have to learn how to interact with the patients. The spiritual care, as I told you, when a person is facing physical sickness, that person will be wanting to be away from the prayers and the spiritual things which is happening. Moreover, they come up with the question, why God has given me this? Why God is allowing me to go through this pain? Why not so-and-so is not having the problem? Why only me? And you being a nurse who is there to take care of the patient, you need to have the answer for the questions what your patients have. For every question, you may not be able to give the answer, but there are questions in which you can give the answer. Next slide, please. The physical well-being, when we say, next slide, please. The physical well-being, when we say, it includes the functional ability. The functional ability of the person gets changed when the person is sick. Especially if the person is having cancer, that person may not be able to function the way in which he or she used to function. He may not be able to go for work and continue with the work what he was doing. Like when you take care of cardiac patients, suppose your patient need to undergo open cardiac surgery. One question what they ask is, will I be able to go back to the same work what I was doing? Many a times, answer may be no. You may have to modify the job what the person is doing. Now, the way in which you are putting it to the patient is what is going to make the difference for the patient. Strength. Person may not have all that strength what the person used to have. Person may feel overexhausted, fatigued, and they may be wanting to take rest most of the time. They may be able to sleep for some time, but they may get awakened very often. You may say, you take rest. You may put the patient to rest, but the person may be having all kinds of worries. Who will be there to take care of my family when I am away? Who will be there to earn and give to my family when I am away? And whole lot of questions will be there. And many a times, if it is a person who is undergoing chemotherapy, or if the person is taking some treatment, nausea may be there, loss of appetite may be there, and at times they may have constipation and they may have severe pain. So each of this area we need to give attention to. Next slide, please. Psychological well-being. When we say psychological well-being, a person who is sick goes through a lot of anxiety. As I have told you, a person who is coming to the hospital comes with lot of questions in his mind, which makes him to worry. And he will be having lot of anxiety. He may go into depression because why God has given me this sickness? Why no one else is there to help me out? How my family can run around and complete this? All kinds of questions will be there. And that may bring them into a stage of depression. Enjoyment. They may see enjoyment as something which is not meant for them. When a person is feeling, oh, I'm having this sickness, how can I enjoy life? When a patient is asking you that question, you need to make sure that he is not accepting the sickness as you are expecting. Many a times, we nurses oversee the things. And we often use the term, कोई बात नहीं, ठीक हो जाएंगे, और घबराना नहीं, सब कुछ ठीक हो जाएंगे. That itself is a wrong approach. Why I'm telling it's a wrong approach? Because if you are in that patient's position, and if somebody else is telling you that, are you ready to listen to that? You may have the reaction, I'm the one who is suffering, and she comes and tells me, koi baat nahi, sab theek ho jayenge. After having this sickness, how can things be theek ho jayenge? Patients do ask this question. So you need to be very sure that you are using the terminologies what the patient accepts. They may not see the leisure time as something which they can enjoy. They may go through a lot of pain and distress. They may be having that fear. If I'm happy today, I may have to face some struggle tomorrow. When they are telling that, you need to be all the more careful with what your patient is going through. And they will be having variation in their cognition and attention. Next slide, please. The social well-being. Next slide, please. Yes, in social well-being, we see that financial burden. I'm not able to go for the work. I'm restricted to bed. I may be in my home. I may be in the hospital. But who is going to earn and take care of my family? If that person is asking you that question, will you be able to give an answer? If I'm the one, I may not be able to give an answer for that question. But I need to understand as a nurse, when my patient is having financial burden, we may be giving bill every other day, but he may not be able to pay and clear the bill. You may get angry with the patient for not paying the bill, but you need to realize that they are not able to pay as you are expecting. When they are not able to pay as you are expecting, things are not going to be the way in which you are wanting. Caregiver burden. This is a common problem what we see. Why I say it's a common problem? Because suppose patient's son, daughter, or daughter-in-law, or grandchildren may be there to take care of the person. But they also get tired. They just feel, oh, if somebody is there to relieve me, I wish if somebody is there to take care of the things for me. I wish if somebody could handle the things instead of me. Why? Because that burnout syndrome comes in and they find that they are just unable to cope up with that particular situations. Roles and relationships. Friends, they can't come and spend time with me. My own relatives, they can't come and spend time with me. So there you see a lot of restriction on the patient comes. Limitation of functions will be there because a person, as he was doing the work, he may not be able to do. As his body was coping up with the things, body is not able to cope up. And there will be variation in the affection and appearance. When we say appearance, say for example, a person who is having CA of oral cavity, there will be disfigurement. And when they have that problem, that their figure is getting changed because there may be an open wound, there may be swelling, they may be finding it difficult to communicate with you, they may be having a lot of problems. And in such a situation, are you able to handle? Are you able to help them? That is the question what each one of us need to ask our own self. Next slide, please. Spiritual well-being. In spiritual well-being, we need to create hope along with the suffering. Though the person is suffering, if that person is having hope, then they will be able to fight with the situation and come out. If a person is not having hope, that person will not be able to fight with the situation and come out. They need to know meaning of pain. And many a times we say, Bardasht se bahar hai. When a person is telling that, we need to understand that our patient is going through a lot of pain, which we can't even imagine. Religiosity is another situation in which you may have to help the person because person may feel, I had been praying all these years, but Parmeshwar ne mera prayer suna nahi hai. Are you going to give an answer for such a thing? You may or you may not be able to. Why? Because what the patient is telling, you may not be able to accept. Next slide, please. Next, yes. Here I have put the title as Walking with a Sick Person. Now, what do we mean by that? This is a picture of a patient who was hospitalized for 6 months, and she had gone through all kinds of pains. And she developed a neurological problem which she couldn't come out with. She was on ventilator 5 times. She came out. And whenever I could make a trip to Delhi, I used to go and spend time. How I used to spend time with her? I just used to go, stand by her and hold her hand. Holding the hand, she could feel, yes, there is somebody with me. That whole thing was changed. Next slide, please. In the next slide, you will be able to see that the patient's son is showing her a cell phone in which something of her interest is coming. She was out of the ventilator and son was permitted to go in. Son is showing the picture of family members who are very close to her. And she is having a smile on her face. Next slide, please. She was out of ventilator. She was sitting up. This is the picture of the patient when she came out of ventilator after the 3rd time when she went on ventilator. But we lost her on 30th of May when putting on ventilator also couldn't help. But all the while, the family had the satisfaction that they have done whatever she could. She was a person who was giving lot of value for my work. And once I went to see her, her son and daughter-in-law was with me. The moment she saw me, she smiled. She put out her hand. Son and daughter-in-law said, "No, that hand is not clean, don't touch." I said, "No, that won't make any difference because she is needing me to touch her. She is wanting to experience that touch. And it was my role, my duty to give her that satisfaction." When I was holding her hand, she gave me a broad smile. She didn't talk, but she gave me a broad smile. And that was giving me a lot of satisfaction. As nurses, we all can do these small things. When our patient is putting out hand, asking you to hold her hand, why can't we do it? It won't take any extra time. It won't take any extra effort, but it takes always your willingness. Next slide, please. When we say palliative care, the main goal of palliative care is achieving the best quality of life for the patient and the family. When we take the example of this family was going through a lot of pain. Family needed the support, and I could only call them and talk to them. But that itself was giving a lot of comfort to them. When we nurses are ready to listen to the cry of the patient and listen to the cry of the family, we are helping them to a larger extent. Next slide, please. Essential components of palliative care: hope, honesty, and openness. We need to create hope in the patient. We need to be honest. We can't go and tell the patient, "Look, you will be getting all right. If you undergo the chemotherapy or if you undergo the radiotherapy, you will be all right." Now, please don't give such false reassurance to the patient. If you are keeping silent when you do not know the answer, that helps the person to a larger extent. And many a times, Your silence speaks much more than the volume, what you are wanting to tell the patient. And in this, you need to give psychological support and symptom relief. For that, you need to have teamwork and partnership. You alone as a nurse will not be able to take care of a patient who needs palliation. What you can do is you may have your team members, doctors may be there, physiotherapists may be there, clinical psychologists may be there, a whole lot of group will be there. And when all of you are putting in the effort together, you will be able to bring out good outcome for the patient. Next slide, please. In palliative care, next slide, please. Palliative care need to be patient-centered care. You should not be doing all the things other than taking care of the patient. That should never be. Always, your center of attention should be your patient. Partnership between the patient and carers. When you are taking care of the patient, you are building up a partnership between your patient and the people who are taking care of the patient. Focused on healing rather than curing. When you know that you will not be able to cure the patient, but you can always help the patient to have the healing. Death accepting, but also life enhancing. As many days as the patient is alive, you need to add life to their days. And then only you will be able to help them. Your interaction may help the patient to accept death. I still remember many years back, my one friend, it was almost 28 years back, my one friend who had advanced cancer, she was not accepting it. I went to Ludhiana, spent 3 days time with her, and on the end of the third day, she said, yes, I know that I have the disease. I need to face it. And I left after 3 weeks, she passed away. But I feel spending 3 days time with her was much useful because she could come to some agreement with her, one understanding with her sickness. Because a person who knows that she's having the sickness, she may die, it's very difficult for her to face the family members, tell the family members, and especially if that person is having children, then that person finds it very difficult to accept the situation. Next slide, please. Palliative care services, when we talk, it can be home care, that is, patient is at home and we are extending the care to the home. When you are extending the care of the patient in their own home, like what DNIP care is doing most of the time, you are going to that rural area or the urban area, you are reaching out to the patient and extending help. Medical consultation. You may have a patient admitted in some ward. It may be gynae ward, it may be medical ward, but from there for consultation, they are reaching. Outpatient clinics. Many of the hospitals nowadays, you see the board, palliative or pain and palliative clinics. Those clinics are working as the outpatient clinics. Daycare centers. Daycare centers are taking care of the patients who need palliative care, and by end of the day, by evening, patients go back to their own house. Inpatient care, when you are having a palliative care ward, your patient is staying there and you are taking care of the patient. There are so many hospitals.
Ma'am, you got muted,
Your
ma'am. Please unmute.
The palliative when bereavement support, can you all hear me?
Yes, ma'am. Yes, ma'am. Now.
The bereavement support when a person is facing death, how the family is going to take it up. Are you ready to stand with the family? Are you ready to support the family during that particular crisis situation? Then hospice. There are very few hospice centers all over India, but people who are going, say, for example, Shanti Awareness Southern in Delhi, the care what a person is getting is something beyond our imagination. So when we say a person is needing palliative care, we are able to extend the care to the full extent. I remember many years back when an 18-year-old boy with cancer, brain tumor he had, passed away. After the death of the patient, taking care of the family was more difficult. And when taking care of the family was more difficult. And we were finding it difficult to walk along with the family. But we had to do it. Next slide, please. Communicating with the patient. Next slide, please. Yes. Communicating with the patient. How the patient is addressed. In what environment you are addressing the patient. What is the situation in which you are seeing the patient. And when you are providing a proper environment for the patient, communication makes a lot of difference. I had a staff who had pituitary gland tumor. And to declare that, it was so difficult. The neurosurgeon took me to the ward where she was working. We took her to one corner of the ward. We made her to sit in a room and we called out for her brother and the doctor and myself. We had to tell her what she is going through. The environment what we prepared was a suitable environment. When we said, she looked at our faces, she was watching our facial expressions, our body language, and she was keenly listening. And immediate response from her side was she burst into tears. So the neurosurgeon who was with me said, I'm here to take care of you. That one sentence from the neurosurgeon made her comfortable. She had the surgery, then she had the gamma knife therapy, and in today's time, she left nursing, she is doing a voluntary service, she is running an NGO, she cooked food and served to the patients and relatives who are waiting outside All India Medical Institute, Delhi. I wished to see her. I wanted to talk to her, but she never wanted to face me. But I keep getting the message that she is doing well. So when we communicate with the patient, how we are doing it, that makes a lot of difference. And next slide, please. We need to be good listeners. Like in a normal communication, we need to introduce ourselves. We need to protect patients' privacy. Many a times in Indian scenario, when a person is diagnosed with cancer, relatives, if you are talking about the son, you are talking to the father, or about father, you are talking to the son, immediate response is, please don't tell him, or please don't tell her. They will not be able to take it up. So you need to see how the patient's privacy is considered. You need to have patience. You need to be with the patient and family. You may have to spend a lot of time, and whatever they want to say, you be ready to listen. Do not belittle the problems of the patient. Whatever they say, I'm having pain here, I'm having pain there. Often we nurses say, oh, वो ठीक हो जाएंगे, वो कुछ भी नहीं है, वो ठीक हो जाएंगे. Please don't do that. Do not impose your views and beliefs. You should not be telling the patient and the relative, I think you are having this. I think you are going through this. Please don't give your views, your beliefs. Just be as your own self. Do not sidetrack or ignore patient's questions. When the patient is asking you a question, please be alert and please be ready to answer wherever and whenever you can answer. Do not promise anything that can be fulfilled. There are many things which happens in a person's life, but if you are promising something to a patient, you need to fulfill it. So do not promise anything which you cannot be fulfilled. Very often, we nurses keep promising and we are not able to fulfill. So please don't do that. Nowadays, we may be getting phone calls, we may be listening, we may not be listening. This Monday, one of my close friend and family lost their only son. They got a message around 10:30 p.m. 11:30, they called me. Out of my sleep, I took the phone, I put it off and slept. Morning, 4:30, when I got up, I see the message from them telling, ma'am, he is no more. Our son is no more. We are going to Vellore CMC. He was a doctor in CMC Vellore and he passed away because of acute MI. Now, the family calls me and talks to me every now and then. But the guilt feeling what I'm having is when they needed my help initially, 11:30, I was not available on that Monday night at 11:30 p.m. It's so painful when you are neglecting something or out of ignorance, you are doing something which you could have done and you could have helped the family to cope up better. You are left with a lot of guilt feeling. You may say, it's because my close friends, I feel that. No. If it is a patient, if it is patient's relative, when they need help, you be ready and you will get a lot of satisfaction. You will not have that guilt feeling if you are going to that extent. With this, I'm stopping my talk today. If any of you have any questions, please ask. Next slide. In this, you can see the caretaker is holding the hand of the patient. And this soothing touch is what all of us need to learn. If any of you have questions, please ask.
Or Cora ma'am, shall we keep all the questions towards the end of the session? If you will
Fine.
that will
Okay,
be fine, no?
fine.
Okay,
Fine.
okay, thank you.
So thank you all for the patient listening.
Thank you very much, ma'am. It is really you touched upon all the topics almost. Of course, it is ma'am's experience that tells everything. So now our second speaker is Dr. Bablesh Mahava, already introduction has been given during the welcome speech. So she's an interventional pain and palliative care physician and senior consultant of Ramakrishna Care Hospital. And in addition to all, of course, she is right now in Raipur, I think, but she was in Delhi, and even while in Delhi or even now in Raipur, wherever we are having her presence even in social media. We can see so many of the videos which are of immense importance for the patients, no, these kind of things. So it is a kind of I'll say, ma'am, apart from her responsibilities, duties and responsibilities, it is her individual social responsibility that she is discharging, I'll say. So these kind of attempts by each and everybody, no, see, when we speak about individual social responsibility, I will definitely would like to remind all of you that whenever you get into an auto rickshaw or a cycle rickshaw or whatever kind of thing you are getting into, the person, the guy will be saying, okay, okay, we'll go. Okay, I'm just. But in the meantime, what he is doing, he may be just rubbing in the tobacco in his hand. Can't we just say, why do you do this? Why can't you stop this? Why can't you think of your own children? The we see so many cases, no, where the oral cancer and the disfigured face and all these kind of things, and water getting in means getting out of the mouth through the side holes because of the buccal mucosa and all these kind of things. But if we just speak to those guys by discharging our individual social responsibility, then there will be a little change. At least if you speak to 100 people, at least one guy may be listening, and that one guy will further propagate it also. So that is a necessity that everybody will have to do in our own way. I won't be able to speak about so many things of medical things or anything. So, but ma'am can. But this I can do to the saying to the rickshaw man or the auto rickshaw driver, I can speak. So everybody in his or her capacity. So all the nursing students are here. You are having the role of nurses. Ma'am has already in detail explained how you have to, and everywhere we say, no, just while seeing the patient, or we say, if you see a person without a smile, give yours. So if you can do that, at least to that patient, that will make his day. So that simple thing, no, we can begin with that. So I'll not do blabbering more. So let me invite our esteemed doctor, Dr. Bablesh Mahavar, ma'am. Ma'am, floor is yours.
Yes, thank you so much. Um, Thank you so much, Hamza ji, and the organizers for giving me this opportunity to talk, because this is very close to my heart, and all nursing students are the pillars of our society. So I think the awareness is the key, and Hamza ji knows it very well. So maybe I'm just a drop in the entire sea, but still I'm also trying my best to make all of you aware and sensitize little bit about palliative care. So shall I share my screen now? Yeah.
Yes, ma'am.
It is showing that host disabled participant screen sharing.
Oh, 1 minute.
Yeah.
Ma'am, we are making a co-host you, ma'am. In the meanwhile, can you share the screen, ma'am?
Yeah,
With you?
but I can't share my screen.
Yes, ma'am.
Ma'am, he is doing just a few minutes. He is doing. Dr. Baglesh. You can share now. You can share now. Thank you, Prasan.
Is it visible?
Yes, ma'am.
Yes, ma'am. It's
Not in presentation mode, ma'am.
Okay. Okay. Now it is okay?
No.
Still not on presentation mode, but it can be seen, of course.
No, but from my side, it is coming on the presentation mode. Just a minute.
But here we cannot see, ma'am. It's in only like. Yeah. No. Yes.
Now?
No.
Still no?
No, ma'am.
It's okay. Now it's okay.
It was
Yes.
not coming in presentation.
Now it's okay, ma'am.
Now it's okay. Okay.
Good.
Okay. So the topic given to me is introduction and the need of palliative care. So why we all are gathered here and why we are discussing on this is because it is really a devastating picture as 1 million people of India are suffering from cancer pain. And this pain is very severe, it is excruciating, and it makes the patient's daily living impossible. And it does not even affect only the patient, but also the family and the entire community. So the cancer pain remains undertreated throughout the world. In case if we talk about the evidence of India or even abroad, it is undertreated. And the current status of cancer pain management in India is hardly 3%. So that is why palliative care is the need of an hour, and it is really important to know about palliative care that this is also one of the branch which looks after so many things which I'll be just telling you in a short while. So World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing the problem associated with the life-threatening illnesses and the interventions and the relief of suffering by the means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Optimizing patients' quality of life at any stage of disease. Palliative care is about the incurably ill, elderly, and the dying. Palliative care is the care which is something beyond the medical interventions. So, palliative care is basically a team based approach, and it is the art of medicine which provides us the skills to connect more and to palliate more to ease the patient's suffering. So, it takes care of the patient and the family both. Okay, so as it is a team based approach, the team consists of a primary physician, psychologist, pharmacist, occupational therapist, nutritionist, social worker, as well as a palliative care certified nurse. And in case if no one is there in the team, a palliative care primary physician and a certified palliative care nurse can do the job. So that is why it is very important to know the crux and to sensitize the nursing students about the need of an hour, that what is the role of palliative care in cancer as well as in any other chronic illness, and with the patients who are dealing with the who are suffering from the life limiting illnesses. Okay, so as soon as we listen to the word palliative care, cancer comes into our brain, that it is only for cancer. So let me tell you that cancer patients are only 28.2%, and rest palliative care can be involved and can be integrated into all the other illnesses. For example, the lung diseases, chronic ischemic heart diseases, non-ischemic heart diseases, cerebrovascular diseases, so many other ischemic diseases which has no curable illness. Sometimes
Ma'am, your slide is, excuse me, ma'am, your slide is not moving, it's not changing. It's only on the front, this
okay,
first
okay,
slide.
okay. I'm so sorry. I'm so sorry.
Yeah.
So, is it possible someone to share, because it is changing on my this thing?
Yes,
Shall I
ma'am. I can.
shall I stop sharing?
Yes, ma'am.
Okay, okay. I'm so sorry. Okay.
This one only, ma'am. Which slide?
Yeah. Okay. Next slide. Okay. So I think now you know about what a palliative care is. Palliative care is, it is visible to all now.
It's visible, but it's
Not in the presentation mode.
not in the presentation mode, of course.
Hmm. I think you do the enable
Yes,
editing.
ma'am. Now
Enable
it's
editing.
okay.
Still it is not on presentation mode.
If I click on enable editing, it's getting closed, ma'am. I will check once. Is it okay, ma'am?
Now it's okay.
Now it's
Yeah,
okay.
thank you.
Okay. So that is why what we discussed is that uh, suppose in case if we take it as a cancer, so cancer pain is severe and it is excruciating, which does not only affects the patient, but it also affects their families and the entire community. So it is basically a social problem. It is not the problem of the individual. So next slide, please. Next slide.
Yes, ma'am. 1 minute. It's not moving.
Okay. So the cancer pain is throughoutly it is undertreated, even in Western countries and even in India also. And the current status in India is only 3% of the patients who are having cancer pain is getting treatment. Next slide, please. So I was just telling you about the palliative care definition, that WHO defines palliative care. It is the illness, it is the care as an approach that improves the quality of life of patients and their families who are facing the problem associated with the life limiting illness. So it is the we have to optimize the patient's quality of life at any stage of the disease. So this is something. See, each and every branch can treat the curable illness, but palliative care is something who takes care of those patients who are having the incurable illness, like the elderly patients, like the terminal patients towards the end of their life who are dying. So palliative care is care which is something which is beyond the medical interventions, which is beyond medicine, which is beyond surgery, because each medical fraternity sees about the curable illness. No one looks after any incurable illness. So palliative care looks after the incurable illness of a disease in the patients who are suffering from the life limiting illnesses. Next slide, please. So just in short, it is just a team based approach, and it is that art of medicine which provides us certain skills to connect more and palliate to ease patient suffering. So palliative care takes care of the patient and the family both, because we have to look after both the things together as the definition of WHO is shown. Next slide, please. So palliative care team consists of a palliative care physician, a palliative care nurse, a medical social workers, nutritionist, occupational therapist who can rehab their patients, a pharmacist for the narcotics, for the supply of medicine, psychologist for the counseling, for the moral support, and just to get the best out of them is the team consists of the palliative care. So next slide, please. Next slide. Next slide.
Yes, miss. 1 minute.
Okay, so what is the global need of palliative care is that palliative care, we cannot correlate only with the cancer patients. It is also, it can be integrated into other chronic illnesses. For example, the cardiovascular illnesses, respiratory illnesses, lung diseases, renal diseases, musculoskeletal disorders, tuberculosis, HIV, diseases of the liver, congenital malformations. So these many diseases are there in which you can integrate palliative care in, even also sometimes in gynecological patients also. So it is not only the forte of the cancer patients, it is a vast and a global need is in so many other diseases which are not known to us. So next slide, please. So palliative care is something which provides relief from the pain and the other distressing symptoms. What are those distressing symptoms? Like nausea, pain, vomiting, confusion, then constipation, all those symptoms. So it affirms the life and regards dying as a normal process. We are not hastening death. We are not postponing death. We are just making it as a normal process. Next. Next. Okay. So it intends neither to hasten nor postpone death. Next, please. Integrates the psychological and the spiritual aspects of patient care. So what are the psychological aspects? What are the spiritual aspects that we will see later on? And it offers a support system to help the patient live as actively as possible until death. See, we don't know how much time we are having. We cannot even say to a patient that a few months are left or few days are left, but how many days are left, we have to make those days more comfortable for that patient. So it offers a support system to help the family cope during the patient's illness and in their own bereavement. Next. So it is a team-based approach to address the needs of the patient and their families, including the bereavement counseling also. And it enhances the quality of life and may also positively influence the course of illness. So it is applicable always. It should be integrated in the early course of the disease, not towards the terminal end when the patient is in the end of their life. It should be integrated in the as soon as the diagnosis of the patient is made. Next, please. So whether the disease is curable or not, whether irrespective of the fact whether the disease or a cancer or a tuberculosis is treatable or it is not treatable, we should be able to control symptoms with a person-centered approach like the pain, nausea, vomiting, fungating wounds, bed sores, incontinence, confusion, and breathlessness. Why? Because suppose a patient comes for a simple hernia surgery, and the patient is taking pain along with that in a post-op phase and is getting discharged. So this always gives will be there in the subconscious mind of the patient that this surgery or this surgeon or this hospital has given me pain, even they have not treated the symptom. So that is why it always comes into the bad memories of the patient. So it is very important to address this symptom, these all symptom also, along with the main course of the disease also. So next slide, please. So what is a total pain? Why we are talking about all psychological, social aspects? Because this concept was given by Sister Dame Cicely Saunders, who defined the concept of total pain as a suffering that has all the person's components are there. It is not only the physical pain, but also the psychological pain, social pain, spiritual pain, and the financial suffering. See, getting the treatment of a cancer is not easy. It is not easy for even for a lower or a upper middle class family also. So that is why it is a very, very, very expensive treatment. So it is important to address the financial suffering also in any chronic illness, and this is the only department, palliative care department, who looks after all these features. Next slide, please. So what is the psychological domain in this? So basic communication skills to talk to the patient and the family in a supportive way. Communication is the key, as it is said by professor also, and healthcare professionals involved in the care, family, friends, neighbors, colleagues with whom the patient spends most of their time. So we have to involve their family also into their care, and we should ask their help also, because it is important, because a person knows all these friends and their family, they are much more comfortable, they can share so many things with them. So that is why we should take the help of their family and friends also, and their colleagues also, in this overcoming in this psychological domain of a patient. Next slide, please. So what are the social domains? Is addressing the social determinants of suffering. So we should never keep a patient socially isolated, because so many times so many things of disfigurement is there, so many wounds are there, and they just want to keep themselves in a social isolation. Sometimes there is a hitch that this disease might occur to a younger children in the family also. So that is why the family keeps the patient into isolation, which is not a right thing. Probably problems caused by gaps in social cohesion around the patient. The final solution in a society which works towards the well-being of all its members creates sense of belonging, promote trust, and offers its members the opportunity of upward mobility. Next slide, please. So what are the spiritual domain? Something we cannot relate this spiritual domain with the religion. It is something which provides each and every person has something, some or the other reason to live. So what is that reason to live? We have to find out, we have to work with the patient, we have to make our family also understand that how to find out the reason, that what is the reason behind this. See, how many days are there, we don't know, but what the patient likes, what are his likings, how can he distract uh, his pain. All these reasons we have to find out to support, and for the family also to for the better coping. These all comes under the coping strategies. So next slide, please. Now how can we do all these things? Like what is the as we are saying that palliative care is a need of the hour, but how to know that which patients require palliative care or which patient doesn't require a palliative care? So this is a very busy slide. It is just a SPIC tool. This is a simple, very simple tool. It is a supportive and palliative care indicator tool, which tells you about certain symptoms and certain signs. It tells you about some, like suppose in case of a patient is coming to a OPD and there is a no suddenly the patient has come, there is an unplanned hospital admission, or in case of the clinical visits, the visit of a patient in a clinic has increased so many times, in the last week or in the last 10 days. So this means that something or the other is there. And in case if the patient is having so many other symptoms which are not getting treated, which used to get treated with the conventional treatment before, but now they are not responding to that treatment, there is a overburden onto the this thing caregivers. Now the caregivers, they feel themselves more burdened by the care of the patient. These are all the symptoms, and sometimes the patient loses their capacity for the decision making, what to do and what not to do. So this means that the patient really requires a palliative care. And look for clinical indicators of one or multiple life limiting illnesses. As I told you, cancer can be one, dementia can be one, neurological disorders, heart and vascular diseases, respiratory diseases, and other conditions like kidney and liver diseases also. So these are certain points which can give you a clue that whether this patient requires a palliative care or not. Next slide, please. This is a simple video. You can just paste this link on a Google this thing, and you can just listen. This is hardly a 50-60 second video in which you can there is we have explained nicely a SPECT tool on this video. You can just listen to this because this is a the previous slide was very busy slide. So in case this is going to really help you, so I recommend to see the video and just to get a simple idea that how you can fill this PICT tool and how you can get an idea that which patient really requires the palliative care OPD visit. Next slide, please. So as I always say that two questions while facing a person with incurable illness always comes to your mind, that how can you use your skills and knowledge to reduce his suffering, and how can we make sure that the society around him knows how to support him. So it is not only you who are going to treat that patient, but you should also make the society also comfortable and make the society also in a supportive way to support that patient. Next slide, please. So the objectives are to discuss in the bold recommendations for changing the current cancer care that not only reduces cost but improve the patient's suffering. Discuss why the patient deserve open and honest communication and medically appropriate goal setting. Discuss always the importance of advocating for pain and symptom management to the management committee, to the oncologist, to the surgical or the medical oncologist in conjunction with their other symptoms. Discuss the practical barriers to changing the practice and attitudes of the cancer care providers, and you should always make them understand with communication that this is a need of the hour and it should be integrated in the as soon as the diagnosis is made. So discuss how to be an advocate for your patient and the palliative care field as well. Next slide, please. So better integrated end of life care reduces the fear of abandonment. Planning for a good death won't make the death happen. So people who have discussion with their doctors about impending death have less depression, better quality of life, and use hospice more and longer. Less CPR are required and better caregiver quality of life. So always discuss with the patient because communication is the key. People who use hospice even for a one day lives weeks longer. This has been studied, this has been seen, and it is evidence based. Next slide, please. So palliative care in the outpatient oncology patients is allow the introduction of the palliative care early in the disease course. That is important. Ease of the transition from curative to the palliative goals of care. In case if we integrate palliative care in the very beginning, so it becomes much more easier for the oncologists and for the primary physicians also. So for the during the transition from the curative to the palliative goals, it becomes much more easier. Then the palliative care team takes the upper hand, and the curative team जो है that tries to be at a lower end. So this graph goes like this. So enable the expert symptom management in outpatient setting and facilitate delivery of quality cancer care. Not only chemotherapy and radiotherapy all the time, but give the quality of life. Next slide, please. Allows the oncologist to focus on cancer and their chemotherapy and staging, and save time per patient and allow for higher volume practice, increase satisfaction with the quality of care delivered. Next slide, please. So now, as we talk, as I said in the first slide, that cancer pain is undertreated. Why it is undertreated? Because there are so many barriers to pain management. No one understands what is a pain management, what is a palliative care under management. That is why only 3% of the population in India is getting the treatment, because lack of knowledge, lack of training at all levels. That is why we all are gathered here and we are discussing on this topic, and we are trying to sensitize you that whatever you choose in your further in your career, you might go to a nephro ward, you might go to a ICU, you might go to a OT, and become the in charges also. But this is also one of the department who caters the incurably ill patients, and it really requires a holistic, person-centric approach with a very beautiful and a humanitarian heart. Addiction, dependence, tolerance, side effects of opioids and NSAIDs. There's a opiophobia. People don't want to prescribe all these, and they don't want to be into this. They don't want to. It's not like that. They don't want to relieve the patient suffering, but they are having opioidophobia. So, inadequate pain assessment also is one of the barrier for the pain management. Unless and until we assess, we cannot manage. Next slide, please. So basic message a cancer patient wants to hear in pain is this. He was a professor. This is with due consent from the patient. He is a professor in agriculture university in Bihar, and his wife was suffering from breast cancer. After surgery and everything, she developed a lymphedema, so much severe pain in her right upper limb that she was not able to lift, not able to do any activity, not able to wear her clothes also. We gave her a pain block and the swelling subsided. You can see her hand now, she is able to lift also. So no matter what happens to you, we will not desert you. This is a message what they really want to hear. And you may be dying, but you are still important to us. So that is what is the goal of a palliative care department, is that the patient is really important to us. Maybe the disease is curable or it is not curable. Next slide, please. So the take home message is that the cancer pain is multifaceted, and it is often not static. It is never that it will go on a simple one linear scale. It will keep on waxing and waning. Accept pain as a normal consequence of cancer and minimize its impact on patients' overall health and survival. Try to reduce the pain so that the functionality of a patient improves. So multimodal approach is necessary. That is why palliative care team is required, occupational therapist is required, pharmacist is required, psychologist is required. Each and every person has a big role. Unless and until you are trying to limit the symptom and the occupational therapist is not going to increase the functionality of the patient, everything is just going to be vain. It is of going to be no use. So multimodal and a multidisciplinary approach is very, very, very important. We cannot keep the patient to ourselves. Let the patient go and meet the experts and to take the best from everyone. Individualized treatment according to the availability and the patient's needs, and enhance the functional ability of a patient. Because in case if there is a bedridden patient also, a single movement improves the patient's psychology and the mental status a lot. Next slide, please. So I just would like to end here by saying, can anyone read this?
Yes, ma'am.
Yeah, please read this. I'm not able to see something.
Okay.
Yeah.
The most important lesson that man can learn from life is not that there is a pain in this world, but that it is possible for him to transmute it into joy. By Rabindranath Tagore.
So a very good saying. We cannot deny the fact, we cannot change the destiny. In case if someone is having a cancer, someone is having a cardiovascular disease, something or the other, no one is perfect in their life. But how much we can improve it, how much we can improve the functionality, how much we can improve the quality of life of the patient, that we should work on. So Thank you so much for your patient hearing.
Thank you very much, ma'am. Shall we take the questions later on after Shakila ma'am's
Yes, yes, yes,
session?
yes,
Okay, that'll be
yes.
fine, no? Okay, ma'am. Uh, that was really the role, I mean, the palliative care need and introduction that has been delivered by Dr. Bablesh Mawar ma'am. And she focused on that we will not desert you. Yes, that's it. I truly remember that during 2008 in the vernacular Malayalam newspaper, the one series of articles were there about the palliative care initiatives of Kerala, and that was with the heading "We are with you." And from that only we have got the inspiration and started the DNIP care. So it's not only the doctors, nurses, the common man and all, the media also, the politicians, media, everybody got their own role. So that will be effective, and that will become inspirational also. So the college, of course, and the university can take up with the local media so that the word can spread. And now about the communication, Shakila Murli ma'am is to speak, and Shakila ma'am is there already, ma'am. Yes, ma'am is there. Okay. So before just Shakila ma'am starts, one thing I would like to just to say that that physical care, well-being, everything we have talked about. Sometimes no, there will be some misunderstanding or misconception with the patients and their bystanders also. I have seen one case, say about 6 months back or so, when we went to the first time we went to that patient. The patient was from 2017 on the bed, and the wife of the patient has already given up just because somebody told that when the bed sore comes at the end of life. See, she cared for from 2017 onwards, but the bed sore came, that to a tunnel kind of a wound. Then and she has got this information from some other patients, and by that time she has lost the tempo of caring. So it is that we have to ensure that not only the patient but the bystanders, the family, and everybody, they also should be uh, told clearly what exactly it is, that they should not live with a different kind of wrong notion or anything. So that is also one of the roles the nurses can definitely act upon. So Shakila ma'am, the floor is yours, the communication as always. Please ma'am.
So, good afternoon, everyone. I thank the organizer for organizing such a meaningful topics. Especially, I want to thank Dr. Roy K. George TNA, our president, and Dr. Rajeshwari ma'am, and also Dinip Care, our secretary, Mr. K.V. Hamsa and Mr. Suresh. So, I would like to share the slides. I would like to share the slide from.
Go ahead, ma'am.
Yes. Can you see?
Not yet. Or if it is available with Lavanya ma'am, can it be?
Yes, sir.
Shakila ma'am, Lavanya ma'am can share it.
Yes. Okay, I can. I'll try to share this.
Ma'am, can I or you want to share them?
Are you able to connect?
Yes, ma'am. Can I share the screen then?
Yes.
Okay.
So today's my given topic is basic communication skill in palliative care nursing. Here I want to
Presentation mode lo petla.
Ma'am, I kept it in presentation mode only, ma'am.
No.
No, it is not.
It's not a slideshow.
Is it okay, ma'am?
Not yet.
Others can view it. I can present.
No, not slideshow mode.
Yes. Okay, I can start now. The word
Ma'am?
communication is yes.
You
Slide
can go
is
ahead.
on.
Go ahead, ma'am.
Okay. The word communication is descended from the Latin word communicatio, which means sharing and impacting. Nobody is born with a good communicator in this word. Slides? I'm not getting the slides.
Yes, ma'am. 1 minute, ma'am. 1 minute.
So nobody is born with a good communicator. It's a learnable skill. So even our basic nursing, we learn the communication topic, but still in palliative care, why it is important, what are the barriers, and how do we communicate when difficult situation, when the patient is suffering. Next slide, please.
Yes, ma'am. Is it okay?
As I said, communication is a trainable skill. We learn and we practice. That is more important. Proper communications are vital for the well-being of the patient as well as for the family. Even within the interdisciplinary, it is very important. Interpersonal relationship as well as with the multiple disciplines, how we communicate is very important. Communication is a vital as basic needs, and apt communication is no less than an art. So it is like how basic needs are important, same way communication is a vital need of a person. Next slide, please. So in this presentation, we just briefly describe why communication skills are important. It describes the barriers to effective communication, recognize the do's and don'ts of communication, enumerates the steps of effective communication, and describes the steps of communicating bad news. Next slide, please. Why communication is important? The aim of palliative care is improve the quality of life. Next. So to improve the quality of life, what is our vital? Dr. Kora was telling the total care, physical, emotional, spiritual, financial, and social, these are. So each need to improve the quality of care, each care is important, as well as in each care, communication impacts major role in that. Next slide, please. So good clinical communication will help the patient to express his needs to the treating team better, because unless we spend time, we'll be busy in doing a lot of things like procedure oriented and things, lot of finishing up, but spending few minutes with the patient, that brings a lot. So nurses are the person who are there 24 hours with the patient. That's the only nursing person. That means no other professional stays that long. So when we be with the patient, when we spend some time, just casual talk. So they develop trust in us and they're sharing the whatever not shared to the other people, they'll be sharing to us. So it helps to clarify doubts and the baseless apprehensions, and it helps the nurse to understand the symptoms and in detail, because when we say it is symptom impeccable assessment, so that also help the patient to understand how much we show interest in assessing the symptoms, the sequences, and the impact of the patient's quality of life. Then effective communication helps to build the trust that will sustain long-term clinical relationships. So our palliative care patients are not like any other OPD. They comes one visit, two visit, and they'll be coming till death, even the relative visits, even after death, the family, bereavement support. So we will be having a long relationship with the patient and the family also. So it is very important to develop building the trust in that. Nurse is the center of clarity to allow shared and the balanced decision to evolve. So we will be the advocate for the patient and the family. When the patients are not able to communicate to the doctor or the other professionals, they'll be sharing with us. So we will be the voice for the patient sometimes, to the family also when they come for the rounds or anything. So that's why the communication skill is very important. Next slide, please. Next slide, please. Which are the areas where the communication skill becomes essential? So while providing information in a supportive manner, it should be concerned. That's empathetic manner. We have to give the information, not like just putting word and throwing word. It should be empathetic manner. And while making a shared decision making, while making decision, how we are showing concern in them and help them to make decision. So we may not make decision, the family, but we will be helping them to make decision in supporting them. Recognizing and responding to patients' cues for information and emotional support could be a verbal or non-verbal clues, and soliciting the patient consultation agendas and delivering the prognostic information. Some patients may think only physical things they'll be sharing during rounds, which ask the previous day, or the reports they'll be asking. There are other things, other concerns they would have shared. So that will help us to deliver the information during rounds also, and will help in the prognostic also. And responding empathetically to the patient, checking patient understanding, how much they understood. See, communication is not only giving information, what a person perceives, that is very important. It's what is reaching to the patient, sir. To from one person to other person it goes, and what they perceive, because when they are too ill or life-threatening illnesses, their minds are blocked. So when you go back and ask what is conveyed to them, maybe may not tell fully. So you can always check their understanding. Encouraging the patient to ask questions, and during breaking bad news, I'll be talking later, breaking bad news, handling pollutions, and discussing the transition, the goal of care from the curative to the palliative, the transition period, what is their understanding, while discussing how we have to do, what are the do's and don'ts, will be looking into that. Next slide, please. What if we fail to communicate, or if what we fail to communicate in a wrong way or not a good way? Why is it may lead to poor symptom control, because patient may not express the problems and they may not give a feedback. When first visit, when we do properly, the second visit patient comes and tells in detail about each problems. So that will help us. Compliance of the patient will be better. So that helps in better symptom control. Patient may not comply with the plan of care as they meet, agendas have not been discussed and supported. So always, in palliative care, all the other two speakers said it's a patient centered, not the disease focused. So when we are mostly patient concerns and the family concerns are discussed, their priorities, and the adjustment to the illness and the interventions would be poor, and this can lead to the worsening of the distress. So could be a physical distress or spiritual distress or social distress also. Could be anything. So we have to how they cope during their distress. That is very important. How are we going to help them during their distress to cope for the better quality of life? There can be a situation with escalating conflict. So conflict with the family, conflict with the patient, conflict with the caregiver. There are different conflicts. Could be some conflicts, healthy conflicts, some conflicts go worsen the situation also. The team does not communicate effectively may find an inquiring patient as too demanding. This can be impact the therapeutic relation. Means they may be clarifying their doubt. They may be asking some question because it's their problem. Their loved ones, they are so interest means that is their responsibility of the family members to do. So they may be asking such repeated questions. But we should not take it. Wait, same question they're asking 10 times. Why they? How many times to tell them? Don't get irritated because that if you show your face, if you show your tone of your voice in a differently, that impacts them. They say they don't come again with the doubts to clarify. So you may be thinking if they do in a different way, so you will label difficult person, always asking irritating question. That irritating person, don't do that because every human come to us as a learning. We are learning from the patient in a different way. So how we communicate better way, that every patient is a learning tool for us. Every situation is important to enhance the quality of life. So medical legal problems also stem primarily from the poor communication and the misperception and the misunderstanding that ensures. So that doctor said, this person said. So sometimes nowadays they record also. This is what they say, they record, and the legal documents, what we do, that also communication, the documents, they quote those words, and because patients are there, are first priority, and the families in a healthcare team. Like Gandhiji says, no, they are the first centered person, like Gandhiji also says. So similarly, when they come with the problem, we should be polite enough, however they are angry, however they are distressed, we should be able to handle. So unless we learn those skills, it is because usually what we learn, no, we learn through role plays and we practice those regularly, then only we develop the skills. So these all concerned as a soft skills. Next slide, please. So communication skills, core principles, you respect the person. You may be thinking because they're coming to you, they not know more, they're less than us. They, however they are our customers. They say no, customers. So you respect whether small person or big person or poor or rich, whatever the religion, whatever it is, respect the person and give your empathetic, not the sympathetic, not like that. Empathetic, you have to show your empathy and trust whatever they say, and trust. And you, if you have any doubt, discuss, but it should be confidential also. The communication, some of the issues are confidential. So discuss among your team whom you can discuss, clarify your doubts also, and unconditional positive regards. This is as accept them as they are. That is a unconditional positive regard. Whatever situation they are, whatever condition they are, accept them. They may be Sometimes example, prostitute or thief or beggar or whomever they are, accept them what they are, because they are our customer. We are there to provide care for them. We are called for the care, to give care, quality of care. We are called. Okay. So these are the core principles of communication skills. Next slide, please. What is not communication skill? General conversation, just talking and going is not a communication skill. This means that talking with the patient and general conversation topic like travel, like politics, where it is not considered communication. So general topic is not communication. You have an core value on the communication and convincing the patient without the agenda, like jolly along words if you're talking, and make them that situation happy is not a, that means that situation means you think patient will be happy when you put a lot of jolly along words. Okay, it will be all right, that without, but patient is very clever to understand why you're telling those. So convincing and conversing is soothing, that gentle manner and kind tone alone without empowering. So kind tone without empowering is also not a good communication skill. So it should be a meaningful, and what the patient information, that with the clarity, what we communicate, what the message we are going, which is going to help the patient is a communication. Next slide, please. Next slide, please. So barriers to effective communications are for the professionals. Many times we look so busy and spending a lot of procedure oriented, assignments, completing the assignment. Patient, so many times in the ward I've seen people, wait a minute, wait 2 minutes, I'll come back. It will maybe 20 minutes, will be postponing the 2 minutes. So just clarify the doubt. Even 2 minutes you spend, yes, I have some work, I'll finish and come and talk to you, but still I'll spend time with you. That makes sure you just continue to give a promise, and you commit the promise what you have given to the patient, and worried about upsetting in the patient and handling reactions. Like an example, children ward and all, some people tend to escape when the children cry. They may not handle the children's or burden, or the similar family member. You may correlate with the similar family members. You may not handle those situations. You tend to escape. So having the knowledge and the skill how to communicate, having the knowledge of the patient and the disease condition, the values, you may not know. Say they may, patient have asked earlier, you may not know, you didn't go and check, so you don't want to go to the bedside at all. That kind of things also we have seen. So make sure, get knowledge about the patient and the family, about the disease condition, about the drugs, the knowledge, everything that really helps us to prevent the barriers and uncomfortable to enter into the unpracticed areas of interaction. How to say I don't know. So nobody is 100% knowledgeable. So, but we have to increase the knowledge. But if you don't know, please tell don't know. That patient will respect you instead of blabbering, wrong answering. If they find to know it is wrong, they won't respect you. Familiar and easier to concentrate on physical concerns. So you'll be tend to avoid the social and spiritual. You may not, if you're not familiar, you tend to avoid. May not perceive the communication as a part of the job. Worried about being blamed and worsening of situations. It's a difficult questions. You may not able to answer, but you can refer to somebody those things whom you know, or you discuss with the seniors, and just tell the patient. So I'm not expert in this, but make sure that you somebody who come and meet you to clarify your doubts. That really helps, and patient also will believe and respect you. Not knowing the language and dialogue can be a barrier. I'll tell you, non-verbal communication speaks a lot. sometimes means you can get help from other person whom they have the same language. Next slide, please. From the patient side of view, lack of time available with the professionals. So that's what they think they are busy. They only know how to handle the physical things, privacy and confidential. They may not trust you. They won't share their confidence. Like an example, sexual issues. They may not help to. It's not used. The people are not used to talk about the sexual manner. Like an example, husband and wife relationship. Because of that, the family distress patient may be having, especially the patient with breast cancer or cervix cancer or a lot of issues. Though they'll be thinking you may be younger to that to express, or they'll be searching for the elderly, but still they won't express. But we all studies all the aspects study, so we'll show general talk. How about your husband and wife relationship? Just gently you talk. That will give us to expose their concerns. And they may be afraid themselves with their fears being confirmed and afraid of treating being denied if they questions, irritable patient or a problematic patient, or some patients I've heard talking one MRO, if they complain the doctor or anything or complain, they may charge more. So that kind of, if I complain why I'm waiting, if they ask questions, doctor may charge more. That kind of fear also they may have, stumped with the medical speech terminology jargons. So better to use a normal language. Like example, nausea means patient may not know. So feel like vomiting, your feeling of vomiting, that small words, avoid medical jargons and authoritative hierarchy of hospital environment. These are the patient's barriers to communicate from the patient side of it. Next slide, please. I said earlier when I studied nursing more than 25 years back, it was 80 and 20 study. Now recent, the Cardiff Research Center, it is said, British one, 93 is a non-verbal, 7% is a verbal only. So 93% we are non-verbally communicate. The posture, gesture, the tone. Next slide, please. Action can speak louder than a word. Like your actions, posture, as I said, there are a lot of non-verbal things you communicate. The way you stand, the way you walk, the way you listen, everything give you whether you're busy, you're angry, or you're really empathetic, your concern, your eyes will tell, the way you nod your head will tell yes or no. Next slide, please. So here I want to say 10 commandments, good communication commandments. Do not interpret, allow the patient to ventilate and listen. That is the thing. When you're ready to listen, they keep talking. Do not give false reassurance. That really, they won't trust you. Next, you keep doing it. Third one, do not compare with the patient. Each patient problem is unique. Okay, each person is unique in the world, and do not be judgmental. Don't go for prejudicial things. So unless analyze and discuss, do that, and do not moralize and do not philosophy. Don't throw away your philosophical thoughts, because their philosophy is different from your philosophy. They may not accept. Do not advise. Communication is giving advice. Or do not assume, and do not sympathetic. Always empathetic. Sympathetic doesn't give help to the patient. Do not use medical terms, I said. So these are the 10 commandments. When you follow, you will be a good communicator. Next slide, please. How can we communicate effectively? They start with the interview greeting, and always when you meet a patient and the family, wish them. That means they think, they feel they are respected, they are recognized, and choose an appropriate place where to talk. No, not talking on the corridors come talk to them, put a hand on them, depends on the culture and religion, establish good eye contact. Depends on the culture also. Eye contact also, it's a culture. When you, in American, if you look straight to straight, eye means they say rude. Where here in our culture, if you put eyes down and talking as though you are made a mistake. So that differs culture also. Try to be in same level as the patient. So when they see there is a lady, when there are, we have a people coming from the lowest of the poorest of the poor, as well as the behaviors, everything. You simplify yourself and like be with them and talk as they are. So they'll be easy for you, them to ventilate and go to their level and talk to them. So introduce yourself and whom you are, what is your concerns and what they want help from us. How can I help you? That really helps us. Ensure patient is comfortable. Make sure, I'm sure you just talk to them and we are there to help. That word really helps. Next. And explain how much time you have available. Just make sure 10 minutes or 5 minutes, but describe those, and that makes 10 minutes valuable to them. And you may have to talk to the relatives separately. Sometimes they want without a relative, patient may express, or relative may tell in a different way. So some togetherness sometimes in a separate way. If you talk, really you get a lot of information about the situation. Next slide, please. And begin with the open questions, because closed questions will give you yes or no answers. So tell about your problems, why, what, that kind of questions. How can I help you? How, that kind of questions will really mix. And that I hear you're having pain, and this kind of look like you're having pain. Where is the pain? Then once you the problem is set, then go to the focus. Did you sleep in the night? That then you, that will help you for your history taking and assessment. But start with the open questions. Patient will start narrating. They won't end up with yes or no, yes answers. Okay, so when you talk open questions, patient start from beginning. You tell about your problem, when it started, how long this problem has been started. They'll narrate in extra information also you get without your knowledge. Patients start telling, and you get the essence. Next slide, please. Like a story, patient will be talking to you. And how is your pain? How can you describe it? Tell me what is going on in your mind. They may tell about the family, children, the talking, the marriage, children, marriage, everything they'll talk. And how did they feel when you were told the diagnosis? So they may go back to their childhood, the sufferings, what they have undergone in the family situation, everything they express. How are you feeling today? But okay, the past, that today, now, how do you feel? That also helps. So these are the examples for open questions. How, and allow the patient family to open up. So that will give you nice description about their problems. Next questions. Next slide, please. Closed questions like yes or no answers. Do you have pain? Are you? These are the closed questions. So this will help in during physical assessment. But when you start any conversation, please always start with the open questions. Next slide. So good communication need good listener. Good listening, you need a skill. You have to adapt those skills. Listen after the open questions. So many people say 2 ears, 1 mouth means double the talk you have to listen. So that's the thing. Listen twice as much you talk. So listening will give you that help the patient to develop a trust. Yes. Next. So listening has different types of listening, like a superficial listening, selective listening, and active listening, empathetic listening. So as nurses, how we have to be, we cannot be a superficial listening or selective. We should be active listening. So our ears hear and we listen with the whole self, everything actively. and make sure show your interest. And that means patient will understand that you're showing interest and you're showing empathetic to them. So verbally and non-verbally, encourage talking, tolerate the silence, give pause. The pause will really help them to come back even after the breakdown, also like emotional breakdown. Then avoid unnecessary interruptions like mobiles, phones, other people peeping into that. And summarize, prioritize the agenda. So after talking, you say, yeah, this is what I understand. Is it anything else I left over? Recapping really helps. And empathize and give realistic. Then plan for the next visit. And this is what I understood. Okay, we will do this. When shall we meet? So next visit, what shall we discuss? These all the things will help the patient to do that. Next slide, please. So when you do a role play, the same things, really you learn a lot. So because it's online, otherwise in a physical things, we do a lot of role play, make them to understand do's and don'ts and what is good communication. And empathetic response, acknowledge patient's feeling sadness. Like example, I can see how much you have suffering all these times and their guilt. Yeah, many patients, cancer patients, I've done this, that's why God has punished me. I've been not good so far. So that's why, or because I had these bad habits, that's why I'm suffering. So I understand those one of the, see, the cancer doesn't have the particular organism. These are risk factors. Even without these risk factors, also patient can have the disease. So tell them whatever's happened is happening. Now we look into the what can I help you in this? How will I help? Those things. Or he can propagate like Mr. Amsa said, they will be propagating to avoid smoking and tobacco chewing, alcohol. They teach 10 people not to do that also. Next slide, please. So here I've given some examples of good and poor communication, open questions, be empathetic. Is your pain is better today? Is close questions. And how are you feeling today is a open questions. Like example, empathetic, I feel like a patient says, I feel very scared and I am short of breath. So you can, these poor questions in these tables, your breathing will improve. No. So first you can recognize the fear, feel scared. Why are you scared? So breathlessness can be very frightening, I understand. And this breathing help us, breathing exercise. You feel we are there to help you. Feel that when you're breathlessness. So these kind of balancing hope and truth. So here I've given those. There is nothing more we can do is poor communication. Here, I am afraid there is no more treatment available to cure the disease, patient may say, but we can care always. There are some medication will help you comfort. Next slide, please. We are with you, we are there to help you. Next slide, please. And respectful confidentiality and avoiding unhealthy curiosities, or also we have to develop. Were you not married then, like that and all unnecessary talking. Next slide. Next slide, please. So steps for effective: build a relationship, open the discussion, gather information, understand the patient perspective, share information, reach agreement and problem, close the discussion sensitively. So these are the steps. Next slide, please. What is not recommended during clinical? Do not immediately reply. Do not philosophize. As I said, avoid comparison, avoid meaningless words, avoid medical jargon, and avoid false reassurance. Next slide. Next slide, this I have explained. Next slide, please. So communicating bad news, there are different steps. We may not be doing the breaking the bad news, the doctors, but we will be helping the patient during the communication, clarifying the doubts. These are the situations where bad communication is delivered to them at the time of diagnosis, at the time of prognosis, terminal illness, at the time of death. These are the times breaking bad news is done. So we will be the key person to help the patient during their emotions or which is not understood. We will be advocate for the patient. Next slide, please. So there are some steps involved in breaking the bad news. It's called spikes, setting up, perception, invitation dose, and knowledge about the information we provide, emotions and strategy and summary. So before that, we have to prepare ourselves like a medical person. We have to prepare ourselves before any breaking the bad news, prepare ourselves and the families. Next slide. Because this is a sensitization program, just we want to give you the information, you can go back and learn it. Slide. The other thing is pollution, withholding the information, because patients and the family shows interest in the patient when they are so affectionate, so the patient may not tolerate. Dr. Kora was also telling about pollutions. So withholding the information to the patient or the family members. Patient may say not to tell my wife. Sometimes the son may say not to tell the patient, cannot tolerate. So this is pollution is addressed when it is hindering good quality of care. So withholding the information will hinder the quality of care, leading the futile intervention, because important things they may not undergo the treatment, which is very important to the patient. So that may not, and as a patient, understanding about the disease and the prognosis and the current situation is, so they need the patient autonomy is respected. And then even the pollution is there, it's harmful to the patient. As I said, they may not cope very well. They keep bargaining and doing those things. They may not happy with the treatment also. Next slide, please. So the steps to manage pollution is convey the relatives that why it is important not to have pollutions. The other side, patient side point of view, we have to express. We will be voicing for the patient, exploring the family's understanding insight about the illness and reasoning, reassess and explain. So they understand their situation, accept, but why it is important, we have in a step by step we have to do. In one stretch we may not do, but in other second visit, third visit, if we are not, they are not allowing us, let the family share the knowledge to the patient. Yes. About the information, what the doctor is conveyed. So these are the communication skills we come across with the patient and the families. So nurses are equipped with these skills will help the patient in quality of life. Next slide. So here I would like to conclude why communication skill is very important, because nurses are the center of the clarity to allow the shared and balanced decision to evolve and based on the patient's value, belief, and priorities, along with the clinical evidence and rationale. A good clinical communication will help the patient and the family to understand his or her perceptions better, remove the baseless apprehensions, and find the support to handle the emotions aspect of illness. Why? This is why we have to equip ourselves and develop this soft skills in communication with the patient as well as other team members, healthcare members also. Next slide. Yes, I'm finishing my topic. Any questions?
Hello.
Yes. Thank you.
Thank you, ma'am. Thank you for the wonderful session, sir. Thank you, Dr. Kora, ma'am, and thank you, Bablesh, ma'am, and thank you, Shakila, ma'am. Is anyone having questions? You can please drop your questions in the chat box. Hello. So I'm going to send you a link in the chat box. So please give your feedback through that link. So I posted the Google Form link in the chat box. Please go through once. So, ma'am, no one is having any doubts. So by this we are good to end. We appreciate your experience and let us conclude for today with a vote of thanks and so I request the Queen Mary chairperson program coordinator. Please give the vote of thanks for that.
Good evening, everyone. Am I audible?
Yes, ma'am.
I take this privilege to propose vote of thanks to the highly eminent speakers, organizers, and delegates of the webinar. We are highly delighted to express our deep sense of gratitude to Professor Dr. Roy K. George, the most impressive and honorable president of National TNA. Thank you very much, sir, for being the initiative to this informative webinar. I take this great opportunity to enunciate our hearty thanks to Dr. M. Rajeshwari ma'am, the Honorable President of TNEI Telangana State. Thank you very much, ma'am, for organizing this event. I take this privilege to convey our deep sense of gratitude to Mr. K.V. Hamza sir for being a wonderful moderator to this webinar. It is our most privilege to thank Dr. Bablish Mahavar, the International Pain and Palliative Care Physician. Thank you, ma'am, for presenting the concept in a more scientific way to the delegates. We are very much thankful to Professor Dr. A.T. Kora, ma'am, for sharing your valuable knowledge and experience with more practical instance. Now I extend our sincere thanks to Mrs. Shakira Murali, the palliative care nurse in charge, CMC Vellore. Thank you very much, ma'am, for sharing your practical knowledge with us today. And thank you each and every participant in this event today. Thank you so much.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे